Good morning, everyone, and good afternoon to those in the UK. Okay, well, thanks very much again for asking me to give this talk. And I wasn't quite sure how to pitch it, so I hope very much that this will be useful as a first talk on diabetes. And what the talk really is trying to do is just talk about what diabetes is and a little bit of a deep dive into what's going on in the body with diabetes and the differences between the two main types, conveniently called type 1 and type 2. I'm sure many people here will be aware that the vast majority of cases are type 2, but type 1 is 5 to 10% of all diabetes in most populations. And I've already been introduced. I am a medical doctor by background, trained in public health, but I don't see patients with diabetes. I have done, but I haven't done for 20 years. So I think it's important to say that in case there's any expectations, but I have spent a lot of my career been interested in, as Isabel said, the distribution of who gets diabetes, how much, and why do some people get diabetes and others don't, trying to understand that. So this is an overview, what would say a bit about what diabetes is, just briefly the number of people with diabetes, and it's a very common condition, as I'm sure everyone on this call is likely to be aware. Say a little bit about that and why we're interested in diabetes. And then what's happening in the body, and particularly with type 1 and type 2 diabetes, and how does it differ between type 1 and type 2? And just for completeness, to mention some other conditions at the end of the talk that also have raised blood glucose. So the vast majority of what we call diabetes comes under the type 1 and type 2 categories, but there are some rarer causes that it's just important to flag, and also some common conditions that people will be familiar with that aren't lifelong like type 1 and type 2, but which are very important. So with that, let's start with a definition. What is diabetes? And I'm using here the World Health Organization definition, and that's a good place to start because WHO really have been responsible over the years, over the decades, going back to the late 1970s, 1980s, of coming up with a standard definition and standard ways of diagnosing diabetes. So that's very important, in terms of what we're talking about, that there's a standard definition and a standard approach to diagnosis worldwide. And this is their definition. A bit wordy, but let's just go through it. So it's a chronic, typically lifelong, metabolic disease characterized by elevated levels of blood glucose, or more commonly perhaps called blood sugar. And it's worth just reflecting on that term metabolic. What is meant by that in this context? And what it really means is that diabetes is a disease that affects the way we derive energy from the food we eat, particularly from carbohydrates. So it affects the way we derive energy. It also affects the way we store that energy in the body, whether it's in the liver, in the muscle, or in the fat tissues of the body. And it also affects the way that we can then access those energy stores when we need them. So that's to do with how we get energy from food, how we store the energy, and how we can access the stored energy. So that's why it's metabolic. It's not just raised blood glucose or blood sugar, but it has these broader metabolic effects and implications. And that is why, particularly when it's poorly controlled, that over time it can lead to damage of many parts of the body, because it is this metabolic, affects many parts of how tissues function. So it could lead to damage to the heart, blood vessels, eyes, kidneys, and nerves. I'm sure many people perhaps on this call will be familiar with the fact of these, and that it's a major cause, for example, of damage to nerves, damage to blood vessels that can lead to lower extremity, lower limb amputations, a leading cause of blindness in many populations, and of kidney failure. So that's a definition of what diabetes is. And just a little bit about how common it is. It's a very common condition. So this is a map. I hope everyone can see this, but if not, I'll go through it just briefly. This is a map from the International Diabetes Federation. And every couple of years, they produce global estimates of the number of people with diabetes. And their main estimates are for adults. So here, age 20 to 80 years old, 79 years old. And what this map is showing is the percentage of the adult population that has diabetes of any type. And perhaps I'll just point out the darker areas. So here, for example, is Mexico. Here's some of the countries of the Middle East with the highest estimated prevalence of diabetes. So greater than 12%, more than 1 in 8 adults in these populations. And actually in some of these populations, much higher than that. And this is actually, you see here, Suriname just highlighted as greater than 12%. And next to it, Guyana, estimated to be, we can debate how accurate these estimates are. They are estimates, and they're produced, as I say, by the International Diabetes Federation. And I'll show you a figure actually, which is a bit higher than for Guyana. But nonetheless, based on these estimates, are roughly around 11%, I think is their figure for Guyana. North America, around the same. And perhaps the big headline figure here is that 1 in 10 adults, 10% of all adults worldwide have diabetes. So it's very common. And that's estimated to be 537 million people based on these latest figures. So a very common condition. And the other point worth making is that the condition gets commoner, particularly this is type 2 diabetes, when we'll come to the differences between type 1 and type 2 in older age. So these are also figures, again, from the International Diabetes Federation. This is showing the prevalence, the percentage of people with diabetes by age group. And these are the figures for North America and the Caribbean. So all the countries of North America, so Mexico going north and all the countries of the Caribbean put together. And really I want to point out 2 things with this really. And the first is how common diabetes is in the over 60s and over 65s. So you'll see here in the over 65 to 69 age group, a quarter, 25%, over 1 in 4 and approaching 1 in 3 in the older age groups of the population have diabetes. So very, very common in older age groups. The other thing I want to point out here is that you'll see in this figure that in each age group, it's estimated that it's slightly more prevalent, it's slightly commoner in men than in women. This is, as I say, for North America and the Caribbean together. The reason for pointing this out is because actually in the Caribbean, that doesn't tend to be the case. And the Caribbean is quite unusual in terms of the world as a whole, in that diabetes tends to be commoner in women than in men. And so here's some data from a recently published study. So this was published a couple of years ago, 2020. It's based on a study that was done in Guyana in 2016. It's for adults, it's people aged 20 and I think to 69 in this study, rather than 79 in the IDF data that I've just shown you. And in this study, it was 1 in 6, slightly less than 1 in 6 men, 15% had diabetes, and 1 in 5, 20%, 21% of women. So it's commoner in women in this study in Guyana. And actually that's the same. We've done work in Barbados, and there are many studies from different parts of the Caribbean where this is a common finding. And that's, as I say, that's quite unusual compared to the world as a whole, where on average, men are slightly more at risk than women, but not in the Caribbean. So let's talk now about what's happening in the body with diabetes. What's going on to cause this raise in blood sugar, but as I say, not just raising blood sugar, these metabolic effects in the way that we generate energy, store energy, and take energy from energy stores. So this is a little graphic. I've taken this from the Diabetes UK, one of their presentations. And the key organ, I'm sure many people are aware, is the pancreas. So that sits just under the stomach. It sits right at the back of the abdomen. So it's underneath most of the gut. It's at the back of the abdomen. And the pancreas has a key role. It produces digestive juices that get injected into the small intestine. So that's one role. But its other role crucial role and relevant here is that it produces a hormone called insulin that helps control blood glucose level and has other effects as well on different, as I've tried to emphasize, on different aspects of metabolism, including how we store fat, for example. So these conditions can lead to diabetes. The pancreas produces no or too little insulin. That's one condition. The pancreas essentially stops producing insulin. That leads to diabetes. And many will be familiar, that's classic type 1, and we'll come to discuss that in the next few slides. Or the insulin does not work properly at the liver, muscle, and fat tissues. So those are the main places that insulin is working. And what insulin is doing is moving glucose from the bloodstream into the tissue. When the insulin gets to those tissues where it's supposed to be effective, and say these are the three main tissues, liver, muscle, and fat, it's not working properly. Or very commonly, a combination of too little insulin and it not working properly. So these factors can lead to diabetes. So already indicated that type 1 diabetes occurs when the pancreas produces little or no insulin. And in most populations, type 1 accounts for 5 to 10% of all diabetes. So it's not, type 2 is much commoner, but still type 1, there's a significant part of the population and significant number of people with diabetes who would be classified as type 1. In type 2 diabetes, the cells of the body, as we've just been saying, particularly muscle, liver, and fat tissue, become resistant to insulin, and or the pancreas doesn't make enough insulin. So the standard way this is thought to happen, or one of the common ways this happens, is the cells become resistant, muscle, liver, and fat become resistant, the insulin can't work as effectively with those tissues. The pancreas tries to produce more insulin to overcome that resistance, but isn't able to. So it produces too little for the body's needs. And this type of diabetes accounts for 90 to 95% of all diabetes. And I would say in the Caribbean, probably closer to 95% and roughly 5% for type 1. But there is a caveat which we could maybe discuss in the question and answer session as to how well we know what the prevalence of these two types of diabetes is, and that become a little clearer when we get towards the end of the talk as to, you know, how does one really determine what's type 1 and what's type 2? Sometimes it's obvious, but it's not always obvious. So really, just to summarize what was in that video, type 1, when glucose can't enter the body's cell because there is no insulin to unlock the cells to allow the glucose in. And type 2, in particular, where the lock is damaged, if you like, and the insulin can't work properly. But as it showed in the video, it can also get to the stage where the body can't produce enough insulin to be able to move the glucose into the cells. So that's a very rough summary. As the video pointed out, the symptoms tend to be similar and the long-term complications are also very similar. So let's just say a little bit now more about type 1, kind of recapping on what was in the video. As the video said, it's an autoimmune condition. So what that means is a condition where the body is attacking itself and the body is producing antibodies to the insulin-producing cells and damaging those. It's not entirely clear why this happens. So there's been lots and lots of research trying to understand this better, and I'll mention on the last bullet point a bit about that. Peak age of onset is in children, as was mentioned. So typically occurs under the age of 40, often, as was mentioned, comes on suddenly as a medical emergency. But there is a big however, and it's important to appreciate this. And this is where it, if you like, gets complicated. Even though when it's, if you like, classic in the way it presents and comes on and then requires insulin to get the person well again, it can come on slowly and it can sometimes develop in a way that might lead you to think it's type 2 diabetes. But the reason it's type 1 is because what's underlying the development of the diabetes is the body attacking the insulin cells, the insulin producing cells. So if you like, it's a type 1 process. What underlies it is type 1, even though it's coming on slowly. So that does happen. And I'm actually a colleague who recently, at the age of approaching 70 actually, developed diabetes. GP, not unreasonably, thought must be type 2 diabetes, but it's definitely type 1. And she is now on insulin, and it was confirmed by measuring in her blood, antibodies to show that yes, her body is in fact attacking the insulin-producing cells of the pancreas. So it's worth remembering, even though it's classically in children, it can actually come on in adults, and it may not have a typical presentation. In the end, however, it will always require insulin for treatment and survival, and that's one of its defining features. And we don't really know what caused it. There's been a lot of research into it. There is a genetic element to it, but it's not particularly strong. So some people, with particular genetic background are at increased risk, but it doesn't completely predict at all that that person with that genetic makeup will get diabetes, get type 1. And there's been research, for example, into things like, viral infections that may trigger it and may set off the autoimmune response. There's been work looking at cow's milk, work looking at other types of environmental exposures, but nothing that really we can pin down and say that's a cause or that's definitely a cause. And if we stop that, we'll prevent type 1 diabetes. If we look now, just summarizing for type 2 diabetes, as we've just been seeing in the video, typically due to resistance to the action of insulin at the tissues, and in the end, the pancreas not being able to keep up with the requirement for more and more insulin. The risk is related to developing to behavioral factors, including a diet high in refined carbohydrates. So for example, sugar-sweetened beverages is one very specific example, is associated with an increased risk of type 2 diabetes if those are frequently consumed. Being physically inactive, both of those can lead to being overweight, and that of itself, as the video mentioned, is a risk factor. And actually smoking tobacco as well increases the risk of type 2 diabetes. It's also influenced by ethnicity, so there are differences between ethnic groups. Actually, the video mentioned people of South Asian origin, and people of African Caribbean origin are also at a higher risk compared to people of European origin, for example, for developing type 2 diabetes. And it does tend to run in families. So if you have a strong family history, so a first-degree relative, then you may be more susceptible to these behavioral factors leading to type 2 diabetes. As mentioned in the video as well, treatments may be perfectly fine to start off with, at least with a healthy diet and increased physical activity. That may be quite enough to get things back to normal, with changing lifestyle, losing some weight perhaps. But eventually tablets and even insulin may be required to control blood glucose. But the distinction perhaps with type 1 would be the insulin isn't required, at least in the short to medium term, for survival, whereas in type 1 diabetes it is, just because the body isn't producing any insulin. Typical onset in middle to older age adults, and I'm old enough to remember when it was called maturity onset diabetes or diabetes of older age. Or non-insulin dependent diabetes was another term that may be familiar. For all the reasons perhaps that hopefully this presentation is helping to show, those terms have been abandoned for the type 2 being the underlying process, insulin resistance, and the pancreas not being able to keep up. And sadly, increasingly, this has been seen in younger adults, and even in adolescents, where there's childhood and adolescent obesity is helping to drive this tendency towards type 2 diabetes. The symptoms, as the video said, are very similar between the two. Typically, more marked and sudden onset in type 1 diabetes, as the video suggested. And a large number of people, because the symptoms may come on slowly, may not be very noticeable, may be associated with someone just feeling a bit tireder than normal in type 2 diabetes. There tends to be a large proportion of people with type 2 diabetes at any one time who aren't diagnosed. And in the Caribbean, for example, estimates, and this is from the International Diabetes Federation, and it's confirmed by some work that I see Rachel is on and Angie's on the call that we undertook in Barbados. You know, around a quarter to a third of people with diabetes, if you actually go out and screen people, haven't been diagnosed. And the reason that's an issue is not because it's inconvenient to have raised blood glucose, but obviously because walking around with raised blood glucose is increasing the risk of complications from diabetes, complications that can then be hard to treat, you know, because the damage can be done. And it's sometimes the case that people don't present with the symptoms of urination, thirst, hunger, and weight loss and blurred vision, but sadly, they present with symptoms arising from the complications, such as loss of vision because they've got damage to the back of the eye, to the retina, or they've got numbness in the feet because of damage to the nerves, because the diabetes has been going on undiagnosed for quite a long time. And that's where the importance of screening and awareness comes in, you know, picking it up early so it can be treated and the treatment can help prevent complications. So just to finish off, really, I'm going to summarize on the next slide the difference between type 1 and type 2. But before I do that, I want to flag a couple of other types of diabetes or prediabetes that you will hear about, and also other rare causes. So in the figures that I've shown you early on, you know, from the International Diabetes Federation or from the study in Guyana about the proportion of the population having diabetes, that's pretty much all type 1 and type 2. But there are other types you'll hear about. So gestational diabetes, it is intermittent because it's to do with pregnancy. It's diabetes, it's raised blood glucose that is recognized for the first time during pregnancy. And typically the raised blood glucose returns to normal or lowers post-pregnancy. But the reason it's important and the reason it's screened for is because if it's present, it increases the risk of complications to the fetus, to the newborn baby, and to the mother as well. And someone who's had gestational diabetes is then at increased risk in the future of developing type 2 diabetes. You'll have come across the term prediabetes, which is what the Americans use and many people use. They use the term prediabetes. The World Health Organization uses the term intermediate hypoglycemia. They're the same. And we could debate as to why one is preferred over the other. Prediabetes is perhaps easy to remember. And all that means is that the blood glucose level is at a level that isn't high enough to diagnose diabetes, but is higher than is what's considered normal. And someone with prediabetes is at increased risk of developing typically type 2 diabetes in the future. It could be a type 1 process, but typically increased risk of developing type 2 diabetes. And this category is important because if you can intervene there, if people can make changes to their lifestyle in particular, they can stop going on, at least a high proportion of them can stop going on to develop diabetes. So those two are very important. They're quite common, but they're not part of when we talk about the number of people with diabetes. These two aren't counted, but they're important categories to be aware of. And then there are some other what I've called here rare causes, so conditions that can damage the pancreas or increase insulin resistance. And systemic lupus erythematosus is one example of that, for example. Cystic fibrosis is another example of that. And the side effects of some drugs, you know, so people, for example, receiving steroid treatment for a health condition, those steroids will tend to increase the risk of developing type 2 diabetes. Okay, so just to summarize, really we've emphasized and spoken about the two main types of diabetes, type 1 and type 2, and this is just a nice figure summarizing what they have in common and what's different about them. So in common, they both cause very similar serious health problems and complications. Both require a healthy lifestyle and medical supervision. And also we've already said symptoms include thirst and frequent urination. With type 1, it can't be prevented. We don't yet know. There have been studies, but nothing yet has really been shown to be successful. We don't yet know how it can be prevented or cured. The body doesn't create enough insulin, as we said, which is the key thing. The pancreas actually in the end stops producing insulin almost totally in most people. We don't know the causes, but there is a genetic tendency, but it's not a strong genetic tendency, and it requires insulin for survival, insulin for life. With type 2, it can be prevented through lifestyle modification. There's also some evidence, which isn't controversial, but it's difficult to know how easy it is to implement. And that is there's some evidence if someone who is early in their diagnosis of type 2 diabetes, if they're able to make some fairly drastic changes, and they are often quite dramatic changes in terms of weight loss and lifestyle change, that they can put it into remission. In other words, they no longer have a diagnosis, they can put it into remission. And that's something perhaps we could speak about. So it can be prevented, and it may be possible in some situations to put it into remission. We said it's due to the body not creating enough insulin or developing insulin resistance, the combination typically of the two. It's more common with aging, as I showed on the slide, of the increase in diabetes prevalence with age. Obesity, diets high in refined carbohydrates, low levels of physical activity. And it may require insulin at some point to control blood glucose adequately. So I'm going to stop there. I hope that's been useful, and I'm really happy to have any suggestions for how it could be improved, and also, of course, any questions for discussion. Thank you very much. What kind of tests? Well, I suppose there are two main tests. Well, I suppose there are three approaches. Let me take one step back. So the test to determine whether you're pre-diabetic or not, the actual test is whether or not you have raised glucose. And that can be determined in two ways. Typically, it could be that you fast overnight and you have a fasting blood glucose measured. So fasting glucose taken in the morning before eating. And if it's in a certain range, that would be classified as pre-diabetic, so below the diabetic cut point. Or very common nowadays, because it's much easier, is to measure something called glycated hemoglobin, or HbA1c, which essentially is given a measure of your glucose on average over the previous few weeks. And again, there's a range for that defined both by the World Health Organization and by the American Diabetes Association, for example, and by others, that would put you in the pre-diabetic range. The reason I said there were three is that in many populations there is awareness raising, and which would be if your body mass index is above a certain level, if you're above a certain age, and if you're, say, from a particular ethnic group, then there might be, say you should really make a point of getting your blood glucose tested. And so there are campaigns around that, which I know go on in the Caribbean, and there's campaigns like that in the UK as well. So, for example, for me in the UK, above the age of 40, in theory, I should be getting tested every 3 years, because that's now thought to be worthwhile for the reasons that we've said, that it's worth picking up either to prevent, or if I've already developed it, to prevent the complications. So you're in milligrams per deciliter, is that right?
Correct.
Okay, so for milligrams per deciliter, there are a couple of ranges, but the ones the American uses is 100 milligrams up to 126. So 126 would count as, above 126 would count as diabetes. For the WHO, it's 100 up to 110, sorry, up to 126. So there's some debate as to what level is the evidence strong that you should intervene. But I guess the short answer is ideally, if you're below 100 milligrams per deciliter, that's considered neither pre-diabetic nor diabetic. Yeah, so I don't think so. There are some risk scores. So I mentioned the risk score, the risk approach before. You know, if you're above a certain age, your BMI is a certain level, maybe from a certain background. And the other thing that's often taken into account in, you know, whether or not you should think of screening sooner rather than later is your family history. So I mentioned for type 2, if you have a first degree relative, that is associated with an increased risk. Cholesterol level has been used in some risk scores. So if you do have cholesterol results, that has been used in some risk scores for saying that put together with these other factors, that also, you know, high cholesterol level is also then associated with a higher risk of diabetes. But without looking at this again in detail, I think I would say these other factors are much more important, you know, body mass index, family history, age, ethnicity. Cholesterol level will make a small difference to you know, very small difference, I would say, to whether or not you're at risk of diabetes. I mean, I should say actually the other lipid, the other fat in the blood that is more closely related perhaps is triglycerides. The triglyceride level in someone who's has insulin resistance, is at risk of developing type 2 diabetes, often the triglyceride level is raised, and that will come down with treatment. So that's often also a good indicator. Yeah, so that's a good question. It comes so above 100, as we were just in response to the last questioner, above 100 classifies as pre-diabetes. Is it a good practice? That's a good question. I suppose the answer will be whether that helps you to take the measures that should help you prevent developing diabetes in the longer run. I think you'd be fine doing that once, once a week, say, perhaps, once a week as a fasting measure, and monitoring your progress, as it were, that way. So is it tending to climb up over time? So I think that would be a suggestion, is that you could perhaps decrease the frequency of doing that, but do it in a way that is allowing you to look at underlying trends. Is there an underlying trend to increasing, to staying the same, or even hopefully to going down? I mean, the other thing that you can do, and that I know people with, some people with diabetes do, is you could also think about, after you've eaten, doing the test roughly 2 hours later. So what's called a postprandial, a post-eating, a post-food test. Well, one of the things that I haven't mentioned here, and it isn't used very much now, because there are because the glycated hemoglobin, the fact you can do a single blood test and on that get an average of your blood glucose levels over time. But one thing that has been used in the past is to give people a glucose drink. So to give you, typically it would be 75 grams of glucose, drink that within 5 minutes, and then 2 hours later to measure the glucose in your blood. And that has also been used as a way of diagnosing diabetes, because the idea is, you're just like in the video, you're absorbing glucose into your bloodstream, and if your pancreas is working well, you should produce insulin and keep the level below a certain level. And so if it climbs above that, that would be an indication of diabetes, or actually of pre-diabetes as well. So you could also, if you wished, I don't want to suggest that you do this unless you find it useful. I think looking at the underlying trend could be the most useful thing. But what some people do is they have the meal, and then 2 hours later, they just see how high their blood glucose is going after the meal. And that would also give you an indication of how well your body's responding to the glucose coming from the meal. Well, when you wake, then a good range would be, so in milligrams per deciliter. So the Atlantic is divided by milligrams per deciliter on one side, which is what the Americans tend to use, and in Europe we tend to use millimoles per liter. So milligrams per deciliter, which I think is what you'll be used to. A range that is less than pre-diabetes is under 100. So maybe, you know, between 70 and 100, something like that would be plumb, perhaps, you know, to use that term, plumb normal. It's always difficult because, you know, what's plumb normal, but around 100 or less than 100 would be good when you wake up. From a public health population perspective, then that certainly would make a lot of sense. I think the short answer is that it needs to be both. I think clearly when someone develops diabetes, one really needs to focus on helping them to lead a healthy life. And I think it's worth saying you can lead a healthy life with diabetes, but you clearly want to focus on preventing the complications, you know, the damage to eyes, kidneys, and nerves, for example. But at the same time, you really also want to focus on decreasing the number of people developing type 2 diabetes, because as I've said, you know, type 1, we don't know how to prevent at the moment. So developing type 2 diabetes. And there are two ways to do that. One is what's often called the high risk approach. That's identifying people who are clearly at risk of developing it in the near future, you know, over the next few years, for example. So they're the people we've mentioned. They're the people whose blood glucose is already a bit high, the pre-diabetes. But there may also the people with what we call other risk factors. So maybe not physically, not very physically active, maybe overweight, maybe a strong family history as well. So, you know, those would be people you'd want to give advice to and support to make changes to their lifestyle. That's the high risk approach. We can also argue that equally important and is the population-wide approach. How can we shift the risk of the whole population? How can we lower the risk of the whole population? So, you know, if, as you say, if it's so common, how can we lower the risk of the whole population? And for example, in Barbados, work that we've done, that Angie and I did, for example, and Rachel, who's on the call, you know, we found that roughly half the adult population were either had diabetes or had pre-diabetes. It was half the population. So how does one deal with that? It would make as much sense to try and look at ways of shifting the risk of the whole population. And one small example of that is is trying to decrease the consumption of sugar sweetened beverages. And Barbados, for the reasons of, you know, the risks associated with sugar sweetened beverages, went down the route of putting on a 10% tax. And there's some evidence that did decrease the intake, and they've just increased it to 20%. So but there are, you know, that's one relatively small measure. There are lots of other things you could imagine doing to try and shift the whole population risk. So the whole population is healthier and at lower risk. Yes, sure. So in millimoles per liter, below 5.6 would be perfectly normal and not pre-diabetic. So the cut point for diabetes diagnosis for a fasting glucose tends to be 7 millimoles per liter. WHO and the Americans differ a bit in what they then say is normal with the lower one for pre-diabetes, but certainly below 5.6 would be considered normal. And some would say below 6.1 or below 6 would also be good. They do have a relation. They often go together. So they do have a relation. Actually, coming back to some of the earlier questions about, you know, when should you screen for diabetes? If we were using the high risk approach, then certainly one argument would be anyone who has high blood pressure should also have a blood glucose test, and vice versa. Clearly, you shouldn't have a blood glucose test unless you're also having your blood pressure measured. So they do go together, and people with diabetes, and particularly type 2 diabetes, often have, not all, but let's say 50% plus, and it depends on the population, also have raised blood pressure. But the treatment for type 2 diabetes, if you're able to make changes to diet and physical activity, that you'd expect that both to improve glucose and to improve blood pressure. But many people are on treatment, on medication, on tablets for both diabetes and blood pressure. The answer is probably yes for the reversal. Yes, so I think the answer is yes in some people and possibly in quite a high proportion of people, which could mean more than half, for example. So this is something that could be the subject of another talk if it was of interest. There's been a lot of work, I think, fair to say, probably led by the UK, some people in the UK. So Roy Taylor is one from Newcastle University. Mike Lean, that's a great name for someone who's interested in obesity and diabetes, but he's based in Glasgow. And they ran a study called the DIRECT study, which was a diabetes remission study. It was funded by Diabetes UK. And what they were doing is they were taking people with a relatively early diagnosis, and they used a cut point, I think, of 4 years. It might have been 6, it could have been 4. So 4 years after diagnosis, no more than 4 years after diagnosis. And then for all of them, they instituted quite extreme, you might say, lifestyle measures. So initially to get people to lose a lot of weight, and then to stabilize the weight. And in that, they were able to show that initially, roughly 70 to 80% put their diabetes into remission. In other words, they were completely off medication. They had normal blood glucose levels. But over time, that number who was still with normal levels has decreased. And, you know, it's gone down to maybe 40% or 50% after 2 years. So quite a lot of people go back to higher glucose levels. And there's a lot of research still going on. This is relatively new research, but it's a lot of research still going on is to say, well, is that just because it's very difficult to maintain the lifestyle changes? And particularly, you know, when the environment around them is such that they're living perhaps with people who enjoy the sugary foods and all the rest of it. So, you know, is it just it's very difficult to maintain those changes? Or is it because actually the body is a progressive condition and the body is finding it harder and harder to control glucose level? So I think my answer would be that if you are able to do it and have the motivation, would like to do it, you have a chance of, if you're relatively early after diagnosis, of putting it into remission. In other words, coming completely off medication and having normal blood glucose, at least for a time. And even if it's not forever, the benefit of at least for a time is it removes the danger while your blood glucose is normal of developing those complications. So you've kind of improved your longer term outlook by having done that. So I think it's worth a shot, and I just you can see I'm hedging because I don't want to give the impression this is definitely possible, but it seems to be possible in some people. So I don't want to give false hope. And we did a study in Barbados, which actually was with Professor Taylor from Newcastle University, just as we called a feasibility study. And people on average over the course of 8 to 12 weeks lost on average 10 kilograms in weight. And a very high proportion of them, they were off medication at the start of that. And at the end of the year, about half were still off medication. But I think so it's this combination of is the body really able to completely go back to normal, but also they're in an environment where it's really tough to maintain that kind of lifestyle and to keep the weight off, you know, going forward. Yeah. There is evidence. This is an area that's hard to study, but there are good studies around to show that chronic stress in particular does have an effect that can make your body more insulin resistant. So in other words, the insulin is working less well at the tissues, as we saw in the video. And one of the problems with measuring stress is trying to define it and then measure what is meant by chronic stress. But the type of chronic stress where perhaps, you know, on a lower income, struggling to make ends meet, types of worry, you know, there is evidence that can lead to a situation that's a little bit similar to if you were taking a low dose of steroids, because your body is in this kind of fight or flight primed condition in a chronic state. And there's certainly evidence that that can, as I say, increase insulin resistance, lead to slightly higher glucose levels, possibly in the longer term, slowly creeping up, lead to slightly higher adverse fats in the blood, so things like triglycerides and certain types of bad cholesterol. And then, of course, the other way that stress can affect it, so it can have direct biological effects. There's good evidence for that. And then the indirect effects of people who are stressed, may understandably use food as a comfort, for example. So you can have both the indirect effect of stress, that using food for a comfort and other things that may be unhealthy. Smoking is a good example, using that for comfort, but alongside also having direct biological effects. So there is evidence that stress, can have that type of effect that increases the risk of type 2 diabetes.
Thank you very much to Professor Unwin for the talk. Thank you to those who joined. We look forward to seeing you for a follow-up.
Great. Well, thank you for inviting me, and well, thank you to the audience. And I'm glad it was useful. Obviously, it's